Okay, let's get started. Hi, everyone. Thank you so much for joining us on your Saturdays for our first workshop. We're really excited for you to have our lung cancer workshop today. We have two awesome presenters, Dr. Safavi and Dr. Chang, who will have introduced themselves right now.
Hi there, I'm Amir. I am currently a radiation oncology fellow at Memorial Sloan Kettering in New York, and soon I'll be coming back to Toronto to be on staff at Sunnybrook at the University of Toronto.
Hi everyone, I'm Eunice Chang. I'm one of the medical oncology lung fellows at the University of Ottawa.
And we also would like to thank our awesome lead content developers, Ali and Anna, for all their work with updating the modules this year. Ali is here in the crowd today.
Okay, perfect. So we just want to talk a little bit more about the ONCARE workshops for those of you that weren't at the opening ceremony 2 weeks ago. So this is our first workshop, and really the goal of these workshops is to provide the most high-yield content for clerkship. And also when you actually do your future practice, regardless of whatever specialty, we hope that this can be helpful. So each workshop will highlight clinical pearls and also important research and advocacy topics in the field. And we also have options for self-learning, which you can do on LearnOncology.Ca, and you can collect points for your team. And you should have gotten an email not too long ago telling you your OnCare ID as well as your team assignment.
Okay, just a quick update on attendance, especially for those who are watching this recording virtually. So for everyone who's here right now attending live, you'll receive 100 OnCare points. And all you have to do is just complete a feedback form that I'll be sending to the chat at the end of the workshop. No need to attach the note-taking sheet that was sent to your emails earlier this week. If you're watching this asynchronously, then you'll earn 50 OnCare points, and all you need to do is submit the feedback form with the note-taking sheet attached. And for everyone who's here live today, we'll be doing a prize draw for some gift cards. So we'll be contacting you either today or tomorrow for the winners of that. And a reminder of the overall requirements for the course. You need to attend 2 workshops live out of 4, collect a total of 300 OnCare points, and this can be through either coming to the seminars, but also through the oncology modules on LearnOncology.Ca that Joy mentioned. And we have a social media quiz series that we'll be launching today. We'll be posting the link to that in the chat at the end as well. And finally, completion of the pre and post-course surveys. Thank you so much to everyone who's completed the pre-course survey so far. If we haven't received your responses, we'll be sending you an email sometime in the upcoming days as well. And so without further ado, we'll get started with the learning objectives. So as you can see, we've had some pretty broad, high-level learning objectives that we hope will be relevant to your clerkships, to your MCCQEs, just talking about the prevalence of lung cancer in Canada, understanding the histological classification, describing approach to patients with an isolated lung nodule, which is a super common presentation throughout a bunch of different clerkship rotations. And then finally, talking a little bit about treatment and motivational interviewing, which are our core concepts of cancer. So without further ado, I'll hand it off to Amir for the first section.
Thanks very much, and it's a real pleasure to join you all today for this session, and really exciting to see so many medical students, kind of the fresh blood of the discipline, having interest in oncology. It's a really clinically rewarding, emotionally rewarding, academically rewarding field to work in, either as a surgeon, a medical oncologist, a radiation oncologist, or even in the diagnostic specialties. So really happy to see everyone, and let's get started. So let's start with the epidemiology, risk factors, and screening. So lung cancer is the leading cause of cancer death in Canada. It is unfortunately still the most commonly diagnosed malignancy. Its scale in absolute numbers, about 30,000 new cases in 2022, and obviously that number has only increased with time. Half of all lung cancers are diagnosed at stage 4 currently, and while we have many better treatment options now, particularly for patients that have disease driven by particular mutations, the survival still remains, unfortunately, overall fairly low. We do hope that, with the emerging advent of better treatments, as well as potentially the role of screening in high-risk populations, then maybe we'll see a little bit of a stage shift in presentations and give us an opportunity to cure patients, whether that's with surgery, radiation, or combinations of all these different treatments. So there is a shifting prevalence of lung cancer in Canada. Historically, there was a high incidence rate. And again, this is a thing that will come up in your exams, as Aaron mentioned, some of these concepts, incidence versus prevalence. So incidence being the number of new cases per year, whereas prevalence is when you take a snapshot of the population and you look at how many of them are currently living with lung cancer. And so the incidence is high, the prevalence is low. And as mortality rates improve, the prevalence of lung cancer, fortunately, continues to increase. So let's do one of these nifty poll questions. Which of the following is not a risk factor for lung cancer? A, COPD, B, tuberculosis infection, C, radon exposure, and D, thermophilic actinomycetes exposure in moldy hay. It's always fun looking at these poll numbers bounce around.
We'll give it 10 more seconds.
Sure. Awesome. Is everyone seeing the results now? Excellent. Pretty good. Okay, so here are the answers. I'm happy to see that radon is the last in terms of percentages, because that's one of the common, unfortunately, drivers of this, are important classic drivers. But yes, the answer is D. It's not associated with lung cancer, but a hypersensitivity pneumonitis, which is a type of interstitial lung disease, which we do sometimes have to think about when we're offering treatments to patients, particularly when it comes to radiation. ILD is a risk factor for severe toxicity, kind of a pneumonitis reaction that could be fatal. And so we have to be really careful when we select patients for treatment. And sometimes it's a difficult risk-benefit decision because obviously uncontrolled lung cancer, it can result in shortening of a patient's life, but the treatment itself could also precipitate that, especially when we're dealing with early stage disease, which is fairly curable. That can be a tough decision to make. Next slide. So what are the risk factors for lung cancer? So in general, when you're dealing with these concepts in medicine, whether it's in oncology or other disciplines, your lifesaver is going to be to have an organized approach. This will allow you to have a framework to come back to, even if you don't remember the discrete elements. If you remember the general categories, whether it's by kind of disease site or pathophysiological process, it allows you to have these buckets to go back to and draw on. So for lung cancer, one approach is to organize into biomedical factors and socio-environmental factors, alternatively modifiable versus non-modifiable. Next slide. So your biomedical factors include your past medical history, family history of lung cancer. While lung cancer, may not have the same family linkage as something like colorectal cancer, or like individuals who have BRCA mutations with breast and ovarian cancers, there is still a component that does seem to be hereditary in terms of increasing the prevalence within certain family trees. COPD, particularly vis-a-vis smoking, which we'll talk about in the socio-environmental. TB and other lung infections, if you just think about chronic repeat insults with inflammation, will increase the chance of having kind of damage and a field defect that could result in lung cancer formation. Prior radiation to the chest. So here you want to have that antenna go off when you're seeing younger patients who've had treatments for pediatric lymphomas in their early 20s and teens. Particularly in the past, there used to be these mantle fields that were used, so really large radiation fields that kind of treated prophylactically, electively, your mediastinal lymph nodes, your supraclavicular, subclavicular lymph nodes in the lower neck, to try to eradicate any source of lymphoma. But that's obviously a large area that we're treating with radiation, and the lungs are sitting right there. And so those patients, we do have to keep an eye out for them for the development of lung cancers, breast cancers in women. Nowadays, we treat lymphoma with much more confined radiation, where we just target the involved node with a little bit of a margin. So hopefully less of a risk factor going forward, but always have that antenna up when you're seeing a patient, let's say in their 40s or 50s or older, who had radiation in the past. Immunosuppression is another factor. In terms of socio-environmental, smoking is the big one. And when we get to motivational interviewing, I hope that we'll get a little bit into the best ways to talk about patients around their smoking histories. It is a sensitive subject, in particular with lung cancer. I think there's often this stigma of patients maybe thinking that they've brought it on themselves, or being worried that people think that about them. And so to then ask about smoking, while it is an important thing to ask about, not just as an academic tidbit, but we also know that, for example, if patients are continuing to smoke through treatment, they do experience worse side effects. There is some data that came out of Princess Margaret, I think a year or two ago, from Jeff Liu that showed survival can be worse as well through treatment if you're still smoking. And so it's important to ask about, but how you do it is really important. Got to be sensitive about it, as well as the wording used. So, for example, in your notes that patients nowadays can read, maybe don't refer to a patient as a smoker, but saying that they've had a smoking history, things like that can go a long way to maintaining a good therapeutic ratio, especially when you're then trying to counsel someone to stop an activity that they've doing for a long time, perhaps to cope with other things. So verbiage and sensitivity is important. Asbestos can be a risk factor for lung cancer, for mesotheliomas, which are a different entity, the pleural lining, giving off tumors. That's an important risk factor, especially if you're, hearing about someone who's worked in the industry in Quebec and places like that. Important to tease out kind of where they worked, and if it's asbestos related, it's an important risk factor. A couple ones mentioned here, which you can review later. Radon, I think, is an important one. You may get quizzed about that even in your med school exams. But certainly if you go into oncology or board exams, that'll come up. Next slide. And so in 2010, in 2020, 1 out of 10 Canadians reported regular cigarette use. So again, as we discussed, really important to tease this out sensitively and then try to get them towards smoking cessation, whether through pharmaceuticals or through behavioral modification. It does make a big difference. Next slide. So in terms of a couple pearls, occupational history, as we discussed, is critical. In general, immunosuppression and prior radiation are risk factors for many cancers, and lung cancer has a strong association with social determinants of health. So just to review kind of social determinants of health, the relationship between neighborhood income and 2-year prevalence proportions varied by cancer type. In this study from the Canadian Cancer Society, for breast and prostate cancers, prevalence was highest among those living in the highest income neighborhoods. The slide just went dark for some reason.
Sorry, one sec. Just gonna reshare.
Yeah, while that slide is coming up, yeah, the social determinants of health are important, even as societal tides may change within other countries and ours. I think it's important still to think about these things. They do have very pragmatic impacts on the health of our patients, and we do need to think about these things and how we can help to modify them, whether it's through better access to care, better access to screening. And so this pattern was reversed for colorectal and lung cancers, wherein prevalence was lowest amongst those living in the highest income neighborhoods. Next slide. It's also important in our Canadian context to think about lung cancer in our Indigenous communities. Risk factors do vary depending on where you live, within a province, within a country, but especially depending on if you're a member of the Indigenous community, you may be exposed to certain risk factors that can put you at higher risk. In several countries, we've seen it's the leading cause of cancer death. And these rates have remained unchanged or declined. Some reasons to think about. Maybe feel free to brainstorm and type in the chat, and then we can recap. All right, why don't we move on? But kind of the general takeaway being, again, these points, systemic factors. So, things that have led to the structures that are in place, in terms of where hospitals are, where certain well-funded hospitals may be, number of doctors that are available, discounting traditional Indigenous healing practices, I think is also an important one. We do have to recognize that there are different epistemological kind of perspectives and cultural perspectives on health and how that informs options that are available to certain people and how they may be important to them. And so it's important to find synergies. You obviously want to be in a position as a practitioner that you're conscious about how the treatments that you offer, whether it's chemo, radiation, whatnot, how they may coexist with other treatments that people may be seeking out. I think a lot of the time there's been this paternalistic perspective in medicine where we want to shut out maybe those other non-Western kind of biomedical options. And sometimes there are interactions that could be dangerous. For example, if someone wants to use really industrial levels of high dose vitamin C and you're getting radiation and may counteract the effect of the radiation. But a lot of the time, these things that people want to try that are important to them may totally be fine to do in conjunction. It's just important to have a dialogue. So I think that's a way to help counteract that. Systemic racism, ongoing issue to deal with. There's community level factors that I mentioned a few minutes ago, vis-a-vis access to care, and then individual factors. So, when there's a lot going on in your life, lots of factors that make it hard to live, you may look to things to cope, to make it easier to live on the day by day, like smoking, less healthy eating. And so these things can increase your rates of having, poor health and lung cancer. So here are a couple of links that our awesome team at ONCARE have put together in terms of links to better educate yourselves, and it's important to do this. We can't always put the burden on our patients, and so when we have resources like this available, important to tap into them to become more literate. Next. So lung cancer screening is an evolving area of research. This is a pretty important area. As I mentioned before, if you can catch a problem earlier in oncology generally, you have a better chance of dealing with it. And lung cancer is no different. So this is some Canadian data, the NLST. I recommend annual low-dose CT screening at 50 to 74, current smoker or quit within the past 15 years, and a 30-pack year smoking history, 20 in Ontario. Now, this is a controversial area. I may disagree a little bit with the slide. So the evidence is weak, may result in overdiagnosis. I think this is academically correct. So, we talk about this issue in breast cancer and other cancers as well, where we want to think about if we're subjecting patients to screening and, the potential consequences thereafter, whether it's extra, scans, biopsies, anxiety. You really want to make sure at a population level that there is benefit, particularly in terms of statistical signals for important endpoints. The gold endpoint usually is overall survival. You want to make sure that this thing you do translates into more people living. The challenge, though, with some of these, cancers is that they still are pretty uncommon, even among, a large number of patients. So even though we said that, prevalence is high, a lot of patients can die from them, among patients who don't have cancer, it's still hard to identify these, early stage cancers. And so it's, I think, not as clear cut as sometimes it's thought to be and talked about in the community. If you can improve something like progression-free survival from lung cancer, you'd need a huge number of patients to possibly translate that into overall survival. But I think there are strong arguments that, if you treat cancers that are earlier stage, and by that metric, you improve progression-free survival, you may give patients more time away from really toxic treatments, from really tough treatments that they may need to be on lifelong, like some of these targeted inhibitors. So I think there is in the lung cancer community a strong push towards trying to improve screening, particularly in the most high-risk populations. There's increased data that's come out of other countries, like the Nelson trial data in Europe, I think in the Netherlands. So it's an evolving area, so keep an eye out for this in the future. There's currently no nationally organized screening programs. Individual provinces have different guidelines. Last I checked, as of maybe a year or so ago, I think Ontario still has their system for screening in some hospitals. So think about referring to patients if you have a hospital close by. Studies are ongoing. Next slide. So now moving on to histologic classification of lung cancer. There are two main histologic subtypes. So you have your non-small cell and your small cell. So that's pretty easy to remember for general medical knowledge. In terms of the breakdown, so they're primarily non-small cell. Within that bucket, adenocarcinoma is kind of where the most of them are. I'd say about 40% overall. Then you've got your squames that are maybe 30% overall. The remaining 15-20% is going to be your large cells and maybe other less common subtypes. And then you have your small cell lung cancer, which is going to be about your 10% or so, 10-15%. Small cell tends to be the one that's associated with a heavier smoking history, but definitely not mutually exclusive with other types. Squamous cell carcinomas may also be at a risk of such. Small cell is really aggressive. So this is one where you want haste. You want to act on things very quickly because the replicative time is really fast. That is a function of the histology. So small cell, blue round cell tumors generally are fast and aggressive. It's named for that classic histologic appearance. And so this is the scenario where, for example, if you have someone with quote unquote limited stage small cell lung cancer, so let's say in a couple nodal stations, primary, it hasn't metastasized, this is not going to be one that you can operate on, and perhaps for a good reason as well, because it's hard to get operating time. So this is one where we have excellent evidence for chemo and radiation together, and it's important to start treatment ASAP. Even though the backbone for local regional control will be radiation, what we often do is just start the chemo ASAP, get the radiation planned, and try to get the radiation started within, the first cycle of chemo. There's some data that says maybe within 28 days, but haste is very important for small cell given the aggressiveness. Next slide. And so this is just a bit of histo. I think more and more with perhaps different pros and cons, we're seeing less histology in medical school in general, but I think just generally this gives you a sense of the aggression. You see how many little nuclei there are in purple and small cell, how many cells that may constitute. And so these cells are very kind of aggressive again. Carcinoid is along that neuroendocrine kind of spectrum again. Mesothelioma is not a lung cancer per se, but you can see that it looks kind of different, kind of more sheet-like along the pleura. In terms of, again, being able to just have some heuristics, if you see someone who has a lot of disease caked in the middle, vis-a-vis kind of a more central tumor near their hilum, lots of nodes in the middle, those tend to be, squames or small cells, not exclusively, but tend to be, and then the more peripheral ones tend to be your adenoids, your large cells. Next slide. So pearls for lung cancer histology, again, small cell aggressive, get going on treatment. Often there could be metastases, so extensive stage disease. Even if someone's in ICU, we can start chemo because if, say, they have a lot of disease that's compromising their airway, you do the chemo, it can start to melt away. It's also important to think about histology when you have a presentation like superior vena cava obstruction. So there's often this concern and urgency to want to jump in and do things really quickly. But it's important to think about what histology is at play, because with our other treatments, you may impede the quality of a biopsy, or you may delay important treatment. So for example, in SVCO, if you're able to get a biopsy, it's not an ultra urgent presentation, which most aren't. If you find out it's small cell, maybe you can start, chemo quickly. If it's a lymphoma, start the right chemo quickly. Try to stay away from steroids if it's, for example, a lymphoma, as it could start confounding your ability to get a high quality biopsy. And then of the non-small cell subtypes, as we discussed, adeno is the most common, tends to be the most common in non-smokers as well. Squamous cell carcinoma, again, about 30%, highly correlated with smoking, perhaps not so much as small cell. Next slide. So workup, approach to lung nodules, this is an important thing to think about as well. Next slide.
Oh, and sorry, Amir, I think we'll transition to Dr. Chang for this section.
Perfect, let's do it.
Okay, so we'll start with another poll question. What is the most common presentation of early stage lung cancer? Coughing up blood, having shortness of breath, having weight loss, or being entirely asymptomatic?
Maybe we'll give it another 5 seconds or so.
Okay.
Some results are shared.
Yeah, so can everyone see the results? Most people got it right. Most early breast cancers really don't have any symptoms, and the reason for this is there are no pain nerves inside the lung. So a small tumor, unless it's actually causing like obstructive symptoms because of its location, or if it's like invading into another structure, it's not actually going to really cause anybody any symptoms that give them any indication that they're unwell, which is why we unfortunately have so many patients who are coming in at an advanced stage. Next slide. So yeah, in terms of like catching early stage lung cancer, most people are caught like incidentally if they're getting a CT or an X-ray, or sometimes they're getting like some kind of cardiac workup, and then they also incidentally find a lung mass. And now, hopefully, with screening programs, we're going to catch more people at the early stage. And then, yeah, whether or not they cause like symptoms, we do divide into whether it's like local to the lung area or systemic. There. Okay. So in terms of like if somebody is having metastatic cancers, you'll want to think about having like B symptoms, which are fever, night sweats, fatigue, weight loss, that kind of, that generalized unwellness. Um, it is non-specific to cancer or lung cancer. So yeah, patients can be unwell for other reasons. And like, that kind of like night sweats and fever kind of thing, you will more often see that with like hematological cancers rather than solid lung cancers, but it can still happen in solid tumors. In terms of if the cancer has spread beyond the lung, it is important to know that different cancers have like different organs that they like to spread to if they're going to spread. So specifically for lung, it really likes to go to the brain, the liver, and the bone. So you're going to want to do screening questions like, are you having a headache, nausea, vomiting, seizures, like difficulties with weakness, sensory changes, and stuff like that. With liver mets, most people won't really be symptomatic with it, but they might have like painless jaundice, pruritus if they're having like like a cholestatic enzyme rise. Patients can get ascites, and if their liver is actually enlarged and they're getting like capsule stretch, they can have pain in the right upper quadrant. And then bone mets are a common problem in lung cancer as well as certain other cancers, and patients can have a lot of pain from them, as well as develop like fractures, which it's very nicely treated by our radiation oncology colleagues, hopefully before they become big problems. And then it's also important to note that, especially with small cell lung cancer, because it is like a neuroendocrine cell origin, sometimes patients will get these paraneoplastic syndromes due to the tumor kind of secreting like active like signaling substances. So patients can get like weird things like SIDH, Cushing syndrome, and Lambert-Eaton, which is like a form of weakness that's kind of rather than patients getting more fatigued with repetitive movement, they'll actually get stronger if they try and do the same movement over and over, which sometimes in internal medicine, they'll like want to get you to differentiate. But if someone has like weird weaknesses, like, yeah, just look into it. Okay. And then in terms of local symptoms, so if patients have, for instance, obstruction of the airways due to their lung cancer, they will have like shortness of breath and cough. If the tumor is like invading into blood vessels, they sometimes can get hemoptysis, which can be sometimes mild or sometimes like life-threatening, depending on the size of the blood vessel that's being invaded. Wheezing, depending on obstruction, and then they can have pleuritic chest pain, especially if the cancer is like invading into the chest wall or the diaphragm. Do note that lung cancer can be considered metastatic, even if it's really still only in the chest area. So you can get metastases to the other side of the other lung, and that's still considered metastatic. Or if someone has a malignant pleural effusion, even though it's still kind of right next to the lung, that's still considered stage 4 cancer. The local lymph nodes in the mediastinum can become like quite large, and you can also get like palpable supraclavicular lymph nodes. So like a head and neck examination is important in a patient where you're suspecting lung cancer. And then Horner syndrome is something that's like pretty rare, but one of those like classic questions that internal medicine doctors like to ask you. So that's where you have a tumor at the apex of the lung, which we call a Pancoast tumor, and it's presses on the sympathetic plexus, and then it causes the Horner syndrome, which is this classic triad of meiosis, ptosis, and anhidrosis. It all rhymes. But yeah, I haven't actually seen it in any of the patients I've been in clinic with. No, move on. So another like thing that people might question you on is like, what is your differential for having an enlarged supraclavicular lymph node? So classically, right-sided supraclavicular lymph nodes are associated with malignancies in the thorax, so the lung and the esophagus. And then classically, a left-sided supraclavicular lymph node, also known as a Virchow's node, is often associated with abdominal or pelvic malignancies. So think like gastric or like cervical, like gynae cancers, but it's not like 100%. Like we get left-sided supraclavicular lymph nodes in lung cancer, but yeah, people may ask you about that. Now, one of the things that you're gonna have to deal with, like pretty much no matter what specialty you're going into, is like somebody with like a CT report that's reporting like a small solitary lung nodule, and then the patient's like, what does that mean? Do I have cancer? What do I do? Like, should I be worried? And then like basically you have to let them know that especially when it's small and like not growing, there are many potential causes of lung nodules, and a lot of them are going to be kind of common in the patients that we're going to see, like who we're working up for lung cancer. So really any like previous like cause of like inflammation in the past can result in a lung nodule. So if a patient has like had like previous like pneumonias or previous tuberculosis, like they could have a lung nodule from that. If somebody has an autoimmune like rheumatic condition, like different inflammatory conditions can also cause lung nodules. You can have entirely benign causes of lung nodules. So something could be a lipoma, which is just a little fat deposit, no problem. Fibroma, just a bit of like, scar tissue. But then you also always have to like make sure that you're not missing an early lung cancer while it's still in the potentially curable stage. And yeah, there's a huge differential, but generally just find some kind of like organized approach that you can like think of the different categories and really just like make sure you're not missing anything dangerous is the main emphasis. Next slide. So in terms of differentiating between a malignant and a non-malignant lung nodule, one of the major things we look at is if it's growing. So it's really helpful if the patient has had like a past CT or a past chest x-ray that you can compare to, like, was it there before? Is it larger, or does it look exactly the same? Sometimes they've never had one, and you're stuck with just like waiting 3 months and getting another CT scan or something like that. And then, the average doubling time for a tumor that is lung cancer is about 100 days. So yeah, typically if you're getting like a repeat scan, we don't do them too early. Like if you do them like 1 month apart, you might not really see a measurable difference. So we generally, like, if we're just following up on a nodule, we'll wait like at least 3 months. In terms of size criteria, the larger a nodule is, the more likely it is to be a lung cancer. So here they're listing like 3 centimeters as a threshold for the terminology between what's considered a nodule versus a mass. But yeah, the larger something is, the more concerned we are about it. And then the radiographic appearance of the lesion also gives us a lot of information. So typically cancers, because they're kind of like invasive and stuff like that, they won't be like nice and round and like well behaved looking. They kind of look spiculated and more aggressive. And yeah, go on. So the Fleshner Society guidelines for lung nodules notes that incidental lung nodules are common, and up to like 30% of people, if you just like randomly CT scan them, are going to have at least one lung nodule, and often they're like completely benign. And they have guidelines to help you determine like what you're supposed to do to manage these based on the size, texture, and imaging features. There's tons of like research going on right now into like different risk scoring criteria to manage lung nodules and ongoing screening, and people are trying to integrate AI and stuff like that into it, but we'll see what comes of that. Like things that might be recommended is like no follow-up. So for instance, if someone has like a very small nodule and they've had like previous imaging that the radiologist can go back and see like it was already there 5 years ago and hasn't changed, then you don't need any further follow-up. If something's like an intermediate risk, then they might recommend to repeat a CT or another scan in a couple months. And then if something looks like fairly high risk to be lung cancer, then they'll go ahead and recommend like a biopsy to figure out what's going on. Okay, moving on. So ultimately, there's a lot of sayings that we say like tissue is the issue, or no meat, no problem. But basically, unless you have pathological confirmation of lung cancer, like someone doesn't have a diagnosis of cancer, so you need some kind of tissue to really like get your diagnosis. And there are multiple ways to get at the tissue. So percutaneously, you can ask like the interventional radiologist in the CT department to go in with a needle and get some tissue out. So this is better, obviously, if it's like a more peripheral lesion that's closer to the outside. One of the risks of this is causing a pneumothorax, which is obviously not pleasant. And a lot of our patients are also, they also have COPD from their smoking, and some of them are on oxygen and stuff like that, which like increases the risk. So sometimes like patients are considered quite high risk at getting a biopsy, and then we run into problems with that. And the patient does not require any like sedation or general anesthesia with percutaneous biopsy. They just get some local freezing. And then next slide. And then another way to get at the tissue is to do a transbronchial approach. So this is where an interventional respirologist or a thoracic surgeon will go in like down the trachea and then into whatever lung that they want to get a tumor at, and then they can biopsy from the inside outwards. And obviously this is better if the lesion is kind of closer to the large airways. If it's in a really distal, like small airway, then the instruments are not able to reach. So this has a much lower risk of causing pneumothorax, but it does require a certain level of sedation. Slide. Okay, this is a video on the process of endobronchial biopsy, but you can go ahead and watch that if you're interested. In terms of other things you want to do as part of your workup, you want to get some basic blood work, which includes, your CBC, electrolytes, kidney function, and then liver function. And then if a patient is having elevated calcium and elevated ALP, that may suggest that they have bone metastases. In terms of staging lung cancer, so once you have, a biopsy that proves you have lung cancer, it's extremely important to know what stage it is to determine the best treatment. So you're going to want to get a CT chest, abdomen, pelvis as your main scan. All lung cancer patients, pretty much, other than like stage 1 that you're not worried about. Other than that, you're going to get an MRI of the brain, because brain mets are super common in lung cancer patients, even if they're asymptomatic. And then if it looks like localized disease, you're going to want to get a PET scan to see if there's any occult metastases or lymph nodes that didn't look enlarged on the CT that actually look active. And then if there are any indeterminate lesions in the bone, you can also do a bone scan to help characterize whether or not they look malignant. Pulmonary function testing is mainly more important to the surgeons to help determine whether or not they think if a tumor is resectable, if they think that the patient will be able to tolerate missing that part of their lung after the surgery. And then the biopsy specimen, in addition to like the normal marker stains that they use to determine that it is looking like a lung cancer, it also undergoes molecular testing to one, get something called PDL1 status, and two, to identify if there's any driver mutations in the lung cancer that would be amenable to targeted therapy rather than our, more classic chemotherapy or immunotherapy. Okay. So just to recap, early lung cancers are often asymptomatic and then caught either through screening or incidentally when you get a scan for something else. Symptoms can be organized into local symptoms like breathing issues basically, and then systemic symptoms. Biopsy is needed for definitive diagnosis, and you're going to want to get that extra workup prior to treatment, one, to determine what the stage is, and then two, to determine how fit they are to get certain treatments. And then staging is according to the TNM system, where the T stands for tumor, N stands for lymph nodes, and M stands for metastases. And then I don't think it's useful for you guys to have to memorize the exact staging criteria for every cancer, but yeah, every time, if you're not sure, just look it up. And there's a link there for a helpful guide there. Okay, so then we're going to move on to how we actually treat lung cancer, with a specific focus on something called EGFR mutated lung cancer, which is a common type of lung cancer diagnosed in non-smokers and has a cool targeted therapy that works really well, and we like to give it to patients because it makes them feel well. Yeah, something to note, cancer treatment is going to be the most rapidly evolving field of medicine that you're going to learn throughout all specialties. I don't think there's another specialty where literally if you learned it 2 years ago and then you propose that same treatment, people will laugh at you and be like, where have you been these past 2 years? It changes all the time. And there's tons and tons of clinical trials that we constantly argue about, and debate, and competing trials that are done with similar drugs, and we argue about which is the best treatment. So it's really not going to be helpful for you at your level to try and memorize the exact treatment path for every subtype of cancer at your stage of learning. But it's so today we're going to focus on the overall treatment principles and kind of classes of treatment. And then today we're going to do a highlight on targeted therapies to help you understand better how that works. Next slide. So yeah, treatment depends on stage. Stage 4, we don't consider curable, right? It's all about controlling things. Whereas stage 1, 2, and 3, we are trying to go for a cure, although the higher the stage, the more likely someone is to have a recurrence in the future and not ultimately be cured. So early stage, stage 1 and 2, the main treatment for cure is surgical resection. However, again, the patient has to have good fitness level. They have to have pulmonary function tests that indicate they'll be able to tolerate however much lung the surgeon thinks they need to take out while resecting the tumor. In terms of staging, unlike other cancers, we always do actual invasive mediastinal lymph node sampling to make sure that there's no occult locally advanced cancer that we're missing. So there's I'd say about a 90% accuracy on a PET scan whether or not those lymph nodes are involved, but that still means there's 10% chance that the PET scan will show negative lymph nodes and the biopsy will show positive, or the other way around. And then, yeah, in terms of like how much of the lung the surgeon takes out, it really depends on like the location and anatomy of what the tumor is invading into, and the blood vessels and airways and stuff like that. So often they do like a lobectomy, and then they always sample the lymph nodes on their way out. But sometimes they can get away with like a wedge resection, which is smaller. Sometimes they have to take out two lobes, so lobectomy. And then sometimes they try not to do this, but sometimes they have to take out an entire lung, which is a pneumonectomy. And then, in terms of what systemic therapy and radiation are for in stage 1 and 2 disease, radiation therapy can still be a curative treatment in someone who isn't considered to be able to like tolerate surgery. For instance, if their lung function simply isn't good enough to tolerate that. And then systemic therapy can be used either adjuvantly, which is after the curative treatment, so surgery or radiation, or neoadjuvantly before the curative intent treatment, where it's the idea is to potentially like kill any cancer cells that might be hiding out in the rest of the body that might later like grow and become a recurrence to increase the cure rate. And then if you give it neoadjuvantly, which is something that's becoming more popular in lung cancer these days, you can also like shrink the primary tumor and potentially like allow the surgeon to take out less lung and stuff like that.
I'll just jump in briefly to annotate a bit about radiation, if we can go back to the previous slide, just for a little bit of kind of general fluency. So the type of radiation that's used as a curative alternative to surgery is called stereotactic body radiotherapy, or stereotactic ablative radiotherapy, SABR, like SABR, SBRT for stereotactic body radiotherapy. So this is treatment that's usually done in 5 or less treatments. If you're treating an ultracentral tumor, so one that's right against like the airway, right against the hilum, that's like 8 treatments just to be a little safer. So this is really high dose radiation that we can use in a curative setting. Otherwise, generally radiation that's used for higher stage cancers tends to be over several weeks, like 6 weeks.
Next slide. Okay, so now stage 3 disease is kind of basically you're going to look at whether or not it's resectable. So some stage 3s are resectable, and then some of them are not resectable. If it is resectable, you're going to do pretty much the same thing that you do like for stage 2 lung cancers, like systemic therapy with surgery. But where it's considered non-resectable, that's where we're going to go in with concurrent chemotherapy and radiation, and still as a potentially curable stage. And this is unlike the, just a few fractions. This is over 6 weeks, and it's like a pretty like hardcore treatment that the patient has to get through. In terms of the chemo regimens that we use in this setting, you're going to see like platinum agents kind of all over cancer because they work super well. And in the curative setting, there's always this argument between something called cisplatin and another platinum called carboplatin, which is usually tolerated a little better, but in the curative setting, cisplatin has a little bit better evidence, so we generally use that as the platinum backbone for all of our chemo regimens. And then we always combine it with a second agent to further help kill cancer cells. And different chemos that you'll see in that setting are things like paclitaxel, pemetrexed, vinorelbine, and etoposide. Now, pemetrexed is a chemo that really only works in adenocarcinoma. So if someone has any element of like squamous cell in their lung histology, you're not going to use pemetrexed. And then etoposide is one of the chemos that we use in cells that have neuroendocrine differentiation. So you'll also see it used in treating small cell lung cancer, as well as like large cell, which is also a neuroendocrine. And then after getting the chemo radiation, these days we then add a year of immunotherapy with a PD-L1 inhibitor called durvalumab. And they're going to cover more on immunotherapy in the breast cancer workshop. But this is one of the cool treatments that's come out in the last like 10 years or so that has kind of revolutionized survival in lung cancer. And then in stage 4 disease, we tell patients that they're incurable. Although one of the benefits of immunotherapy is that even in the metastatic setting, we do get like a significant minority of patients who get these super durable responses where they'll like finish 2 years of immunotherapy, and then the majority of patients who make it to that point without their cancer progressing actually can come off their immunotherapy, and the majority of them actually don't have any disease progression even though they're not on any treatment. And then they ask us like, am I cured? And then we say technically no, but also yes. And it's kind of one of those like murky fields where we're not quite confident enough to call them cured, but it is looking good. And then in terms of in metastatic disease, generally speaking, systemic therapy, either with chemo, immunotherapy, or targeted therapy, or a combination, is going to be the backbone of keeping the cancer under control in general. But patients, if they're having like a single metastasis that's causing local problems, such as, pain or obstruction, or if it's like a brain med that's causing them neurological symptoms, often localized treatment with radiation or surgery can be very, very helpful for, their quality of life and stuff like that.
I'll jump in quickly with 2 points. One, the whole controversy in stage 3 about resectable is still unresolved. The data that Dr. Chang talked about is really compelling with doing chemoradiation, and then if you don't progress, going on to consolidative durva. There is now these paradigms of doing more resections and then doing like the immunotherapy either before, after, or a combination. But the challenge is selecting who is appropriate for resection and possibly not harming patients. So typically, if you have lymph nodes that really are in the middle of the mediastinum, bulky, maybe multiple levels, this has been an area where people have typically left it to radiation and chemo as the primary treatment. But now we have some surgeons who are getting a little more adventurous and bold after, let's say, some immunotherapy response to go in. But there is a concern that maybe you may not be doing these patients the best service. So that's definitely an area of controversy right now. And then for stage 4, I just want to give a plug for this concept of oligometastatic disease, which is this idea that stage 4 metastatic isn't black and white. It's, for example, if disease has spread, but it's in maybe 3 spots, 5 spots, that patient fundamentally has a different disease trajectory and history than someone who has 20, 30, 40, 50 metastases. And that if you aggressively treat all the areas of disease in conjunction with systemic therapy, or a couple that maybe progress while systemic therapy works really well on controlling everything else, you may be able to enhance the time that a patient remains on a drug that works, time away from having to go on a drug, and potentially progression-free survival and overall survival. It's an area that data is still accumulating, but this idea that local management still can play a big important role for these patients with metastatic disease beyond simple palliation for local symptoms in well-selected patients.
Yeah, for sure. Yeah, we love to ask our radiation colleagues to just zap like that one spot that's like not behaving, because we don't want to move on to the next line of treatment. There are really only so many effective systemic therapies in lung cancer, so the longer you can keep someone on an earlier line, the better, basically. Okay, move on. So what is targeted therapy? Like what is that? So this is like even a newer kid on the block, even compared to immunotherapy. But we know that certain cancers are driven by mutations in what we call oncogenes. So these are genes where their normal function is to tell the cell to proliferate, to survive, and do things that are related to growth, but normally they're closely regulated. They have a clear signaling pathway to be on, and then the rest of the time they're off. But sometimes these genes can develop mutations that cause them to be always on. And then if a cell is always proliferating, that it basically is cancer. So we know that certain cancers have certain specific mutations that fairly often happen to cause this uncontrollable growth. And then, people who are better biochemists than I am have developed certain molecules that can go in, block that signaling pathway and shut down that signal for the cell to grow, and therefore keep the cancer under control. So this isn't always, but often the targeted therapy is designed to only act on the mutated version of the protein, which there are some that act on like the wild type, but the ones that are targeted towards the mutated protein often have fairly minimal side effects, because unless like you're a cancer cell that has that mutation, it shouldn't like affect the signaling of the normal cells that much. So these drugs are often quite tolerable. They often act very, very quickly. So like in a patient with like very advanced EGFR lung cancer, they're like very short of breath, losing weight, not eating, stuff like that. They'll often tell us that within days of starting the treatment, they'll notice a symptomatic improvement. And I think they're going to do more details on how targeted therapy works in the colorectal workshop. Okay, so we're going to talk about survivorship and motivational interviewing. So regardless of whether or not someone has lung cancer, not smoking is the #1 best thing that they can do for their health. It's better than starting to exercise. It's better than eating better. It's better than losing weight. It's better than getting control of their diabetes. Just not smoking is like the #1 thing that someone who is smoking can do to improve their health. So if you can like convince like one patient to like not smoke, like you have done a very good thing for them and for society and the healthcare system. Okay, so like there's like tons and tons and tons of benefits. Immediately, patients will like have lower blood pressure, higher oxygenation, better immune system. Their mood will improve, their sleep will improve, their overall sense of well-being will improve. And it's also very important to note that all of our treatments in lung cancer work better in patients who are not smoking compared to if they are smoking. So often like the diagnosis of lung cancer is like a good period to like intervene and get them motivated to like stop smoking, because you're going to tell them like you're going to go on this treatment and it's going to work better if you're not smoking. So if you could just like at least not smoke for the duration of the treatment, like it'll be better. And then, you can kind of push it from there and hopefully they never start smoking again. And there's like definite like overall survival benefit in patients who successfully stop smoking, and decreased risk of getting another cancer down the line. And, we do have patients who have like, 2 or 3 like lung cancers pop up over the years, which is like quite unfortunate. So next slide. So we're going to talk about motivational interviewing. Like, how do you motivate patients to actually like make a positive change in their life? So we're talking about quitting smoking, but this is also related to other like lifestyle changes that you might want to encourage somebody to do. It's really important to express empathy. So I always like tell patients like, I understand like nicotine is the most addictive substance we know of. Like it's more addictive than cocaine or heroin or meth or whatever other like recreational drug like people might know about. Like nicotine is extremely, extremely addictive, and it's very understandable that it's like extremely hard to quit. And like just them like feeling like you understand like how hard of a task you're asking them to try to do is very useful. Avoid arguing. So, some patients are just not in the right like frame of mind to want to quit. They may have, tried to quit many times before, or they, may have like negative experiences with like other healthcare providers, or just people in the general public like judging them based on their smoking. So if someone is in that like frame of mind where they're just like absolutely not interested in talking about it, you don't want to just be constantly like nagging them and like kind of destroying the therapeutic relationship you have with the patient. But definitely just explore their feelings, and if they're giving off signals that they're interested in trying to make positive changes, definitely encourage them in that direction. Roll with resistance is the same thing, really, like you're going to go with the patient and what they're interested in. So some patients, they tell you like, oh, I'm going to quit cold turkey, and you're going to encourage that. Some patients are going to tell you, oh, I'm interested in trying like a pharmaceutical to help me with my cravings, and you're going to encourage that, write a prescription, stuff like that. Develop discrepancy, so you're going to like want to make the patient aware of the downsides to like continue smoking. So we're going to talk about how treatment is like less effective in someone who continues to smoke, and try and like emphasize that, and want like create that like mental like reason to want to quit, and put that in line with their goals. And then supporting self-efficacy is like like giving the patients the confidence that they are able to make positive change in their lives. I always tell patients like it's super, super common to need more than one quitting attempt before permanently quitting smoking. So just because you've like tried to quit in the past and like started smoking again doesn't mean that you're someone who'll never be able to quit smoking and you should stop trying. So really just like encouraging them and giving them the feeling that you believe that they'll be able to make positive change in their lives. Okay, so I think that's all the slides. I think we've gone a little bit over time, but I'm happy to stay and answer questions. There's tons of other extra stuff that you can look at, and I encourage you to learn as much as you can about cancer, because you will treat patients with cancer no matter what specialty you end up going into.
Perfect. Thank you so much, Dr. Chang and Dr. Safavi, for your amazing talks. So just as a wrap up, we saw that you guys have amazing questions in the chat. Everyone seems to be very engaged. So this is an opportunity now. If anybody feels comfortable, you can either write in the chat as well any additional questions you have for our speakers, or you can also even unmute and turn your camera on if you're comfortable. And then we also just have a few links that Aaron will send in the chat in terms of other things going on. So we have our Learn Oncology Instagram page, and we have a weekly social media quiz that was just posted today. So Aaron will be including the link to that. So it'd be really, really great if you guys want to fill that out and test your knowledge. We also have the link to a survey for feedback after this workshop, and that's super important for us so that ongoing workshops, we'll able to tailor that and change things based on what you guys think works best for you. Also a reminder that if you haven't filled out the pre-course survey already, just to do that as well, because it's super important for us, and it is also one of the mandatory components to actually get your certificate at the end. And that's pretty much it. Aaron should have been sending those chat links as well, but any questions are welcome as well for our speakers. And one more shout out for our next workshop. It will be on March 8th. It'll also be a Saturday, and it'll be at the same time, so 12 to 1 p.m. Eastern Standard Time.
Definitely feel free to ask us questions about either oncology, careers in oncology, training, residency, fellowship. Go for it.
As we wait for questions to stream in, just one final update. Sometimes at our workshops during last year's iteration of OnCare, we had small post-workshop talks that were optional components that you could come to if you had the extra time. to sort of learn about extra topics. So we had a topic talk about CARMs for one of them, talking about how to get involved with research in oncology. So we'll be sending out some surveys to see what the interest is in, and we'll try to get some speakers to tailor that towards your interests.
Seems to be a question in the chat. Did you do research in oncology before residency? I can give it an answer first before Dr. Chang. The short answer is yes. The more complex answer is I'd say to the degree that I do it obviously now and I'm interested in it now, no. I would say that, doing some, if you're interested in some kind of oncology specialty is good just because it teaches you more about the field, some of the interesting nuances of how oncologists think, as well as the skills are transferable, right? Like it's just being able to have a deliverable on a timeline, being able to communicate well in a written format or in a speaking format, to kind of deliver your thoughts concisely. So even if you were to do a project in oncology and then later pivoted to wanting to do like trauma surgery or wanting to do RESP or whatever, these skills are all transferable. So if there is some kind of even small interest in oncology now and you find a project, like jump on it, because then you can use that as a stepping stone for something else, or it can cascade towards a larger interest in oncology. So general kind of answer is just dive in med school and take advantage of opportunities and see where they take you.
Yeah, as for me, I didn't actually do any oncology specific research prior to residency. I definitely started once I got into internal medicine, but I did have like a little bit of like other research. I would say like getting into like for the medical oncology path, like you have to get into internal medicine first. So you often have to kind of pretend like you're more of a general internal medicine candidate rather than a medical oncology candidate, if that makes sense. But like getting into oncology research early is like really helpful. Just having a little bit of research on your CV is helpful for kind of whatever specialty you want to get into. And there tends to be like quite a bit like going on in cancer that people can use a med student to help process data and stuff like that. And just doing that kind of work often like gives you a lot of background knowledge on how cancer works. So it is, definitely like reach out, just randomly email oncologists. They tend to be super nice people. And yeah, don't feel intimidated.
Another question here. Are there a lot of job openings post-residency in oncology across Canada? I'll start with the RadOnc end and then maybe Dr. Chan can answer for MedOnc. For RadOnc, I would say the answer today in 2025 is yes. There is a bit of a trope historically that, radiation oncology, there were not jobs. And I would say that was true like until about 20, maybe 16 or so. But there has been a gradual convergence of the supply demand curves to the point that now they are completely crossing. And if not, supply is higher because there is a generation of older radiation oncologists, particularly in Ontario, that are starting to retire now. We're definitely seeing increases in cases, even compared to 5, 6 years ago when I was a PGY1. There are many more cases now as indications change, as the population ages. So there's going to be need. There's going to be more oncology jobs that become available. It's important for the field to caretake itself well so we don't get into a situation again like we did 10, 15 years ago. But I'd say right now, with like a forecast of 5 to 7 years when you guys would probably be on the market, things are looking good in radiation in Canada. General challenges with radiation compared to MedOnc a little bit is there are less radiation centers compared to being able to give many of the systemic therapies in more settings. So there are less centers, but the field is also a little smaller, so that sort of accounts for it. But geographically, they tend to be a little bit more in academic than community centers. That being said, in not every single academic center do you need to be publishing at like some crazy clinician scientist level. So even if you have some interest in teaching, med students and residents, or you want to do just a little bit of research once in a while, you can certainly get academic jobs in Canada. And then there are a couple centers where if you're totally masochistic about research, you can thrive in those environments too. So there's all kinds of jobs available. And in any discipline, you just want to look at the convergence of geography, pay, and what the job entails to see what's a good fit potentially for you.
Yeah, so for medical oncology, like right now, there are multiple job listings open across Canada. That being said, if you are kind of pickier on like the exact like city you want to work in, or if you're like, I really only want to work at a major academic center, there still is like a certain competitiveness for when jobs open, because even with it in medical oncology, you still are tied to like centers that deliver systemic therapy, and you can't just like open a random clinic wherever you want. Um, Again, the average age of a medical oncologist in Canada right now, I think, is like 62. So we are expecting like a huge wave of retirements at the same time that our cancer incidence rates are going to be like, I don't know, like doubling. And because we're getting so good at keeping people alive, like the number of follow-ups we have to see is also like ballooning. So if you're interested in oncology, I think this is like a field where there's only going to be more and more job opportunities in the future. And it's going to be hard to replace us with AI, because we do a lot of like hand holding and reassuring people and stuff like that.
A lot of just interpreting gray zones that I don't think an AI can do quite yet. There's a lot of kind of like not hand waving, but like vibes informed by seeing a lot of patients, by group experience, by the data. So yeah, totally agree. How early on in medical school did you consider doing a specialty in oncology? What factors led you to pursuing the specialty? I'd say so. So for a bit of context, I went to Mac for medical school, so that's a shorter timeline of 3 years. So I was a little bit just pragmatic and strategic vis-a-vis like, yes, one could endlessly explore specialties for a really long time and still maybe like not be sure. So I kind of gave myself a little bit of a parameter. I was like, I want to give myself maybe all of first year to kind of shadow, read about stuff, talk to people, and then just kind of commit to something that feels generally right. I had, done a master's in some cancer research before, but again, very unrelated to what I do now. So I don't think that was at all necessary or gave me profound insights into doing RadOnc. But it put it on the radar a bit. So like I shadowed some surgeons, I shadowed radiation, I shadowed pediatric medical oncologists, and I just felt RadOnc was the best fit for what I'm looking for. You do local treatment. You can do it in a definitive, all in a static, palliative setting. So you can really treat the full spectrum of patients. You can treat children, you can treat adults. You have to learn about all the disease sites, both from like a surgical anatomic functional perspective, as well as, as Dr. Chang was talking about some of those different paraneoplastic syndromes and kind of more internal medicine-y systemic type of thinking. And, the treatments are absolutely fascinating. The technology is changing all the time. So, you have to think very carefully. You're not just stuck in the basement, as some people may think, or in a dark room. You're seeing patients in clinic. You're going to the ward. You're making decisions about, do we give more aggressive treatment? Do we not? Super multidisciplinary, both with like the other, MD disciplines, but also within radiation. So you're dealing with, physicists. You're dealing with radiation therapists. Lots of like troubleshooting, like, oh, this patient's like shoulder is rotated weird each time. Like, how do we reconcile this so like the radiation goes to the same place and doesn't like fry their cord? So lots of, fun on a day by day, constantly stimulated, never rote, even with like quote unquote bread and butter situations. There's always something weird. So very stimulating and fun.
Yeah. So for me, I knew fairly early. So I was in the third year of medical school, and then we had the 4 weeks of like CTU doing general internal medicine, and then 2 weeks of you can do a subspecialty selective. So I did a subspecialty selective in medical oncology. And I remember like a very distinct feeling of like sitting in morning rounds and feeling like I had found my people. And the rest is history. So I would say like as you're, looking into like different specialties in med school, like keep an eye out for like the personality types that seem to be happy in each specialty. And if you find like there's a lot of people who are like just like you, who like super love their job in a certain specialty, you should probably look into doing something like that. I would say like medical oncologists are like the weirdest combination of like super, super nerdy, like love academia, love arguing about statistics and p-values in clinical trials, but also like super empathetic, like love having that longitudinal relationship with their patients and talking to them about their grandchildren and what, you know, their vacation was 2 weeks ago, and really like celebrating that they're, you know, having a good quality of life on treatment and stuff like that. So I really love that like dichotomy of like super nerdy, but not in a way where, you know, I feel like certain specialties tend to be so cerebral that they're not very empathetic with patients. Um, and then the other thing I did as a medical student is I definitely did do an elective in radiation oncology to like see if I like that better. But it has like more anatomy and less medicine, which I actually I'm terrible at anatomy is my problem. So it was not a good fit. The thing you do have to keep in mind in medical oncology is yes, it is a subspecialty of uh, general internal medicine. So you will have to do 2 CARMS matches. You will have to do 3 years of general internal medicine, and you have to like be able to like survive that. Like it is a hard path, but you will come out of it like understanding pretty much what everything in the body does, which is nice and also necessary when you're giving someone like systemic therapy that causes multi-organ failure. So it's really definitely like if you feel like you couldn't do 3 years of general internal medicine, you know, unfortunately, you're going to have to find another specialty. But often, like, even if you don't really love that inpatient grind, like, you'll love the knowledge and the nerdiness that comes with general internal medicine as well.
And to add on to that a little bit, Joy and I are always happy to chat as well. We just both went through CARMS ourselves. If you have specific questions about like finding out what specialty you want to do, the application process, we might do a short post-workshop talk on that sometime during one of the later workshops. I applied to both radiation oncology and internal medicine, so happy to chat with anyone about either of those fields.
Perfect. So maybe it looks like the questions are kind of wrapping up, and also just to respect your time as well as our speaker's time. So I think we'll call that a wrap, but thank you so much again for being so engaged during the workshop. And thank you again to our amazing speakers as well for volunteering your time on a Saturday. I think we all learned a lot and really enjoyed the experience.
Thanks, everyone.